I would like to start by welcoming, our participants. It's the first Renal Grand Rounds for 2022, so we are very, very excited. I'm Penelope Capicino, an associate professor of medicine here at Northwestern, and we have a great speaker with a great topic today. I will let my colleague, Dr. Rebecca Frazier, introduce our special speaker for today's Renal Grand Rounds.
Great, thank you. So we are very happy to welcome Dr. Gretchen Schwarze today to our Renal Grand Rounds. So just a brief introduction. She's had a very impressive training and career. She did most of her graduate education over in Boston. She went to Harvard Medical School and then got a master's in public policy at the John F. Kennedy School of Government. She also completed a research fellowship at Mass Gen at the Transplantation Biology Research Center. And then she went down the street to University of Chicago, and because she didn't have enough training, she did a vascular surgery fellowship there, and also a clinical medical ethics fellowship. She is currently an endowed professor of surgery in the departments of surgery and medical history and bioethics at the University of Wisconsin-Madison. She's a prolific researcher. She has expertise in decision-making, informed consent, advanced directives, and end-of-life care. So Dr. Schwarze will now discuss a current clinical trial that we will be starting here at Northwestern, which examines a communication tool to assist with dialysis decision-making among older adults with advanced CKD. So thanks so much for coming today.
Hey, thanks so much, Rebecca. That was such a nice introduction. I really appreciate it. So I'm going to share my screen and hopefully don't screw this whole thing up. Whoops. Are you seeing my slides or my Spotify?
It's your slides.
Okay, good. And now you're seeing presenter view, right? So I'll switch that. All right. Are you seeing just the slide and not presenter view? I did an entire national talk in presenter view, so I have this PTSD from screwing the whole thing up. So hey, thank you so much for your time. And the short story of why I'm here is I kind of really need your help. But I'm just going to go through the work that I've done and then talk a little bit more about this study that we'd like to do. Here are my disclosures, and of course I'd like to thank the NIH for their support of my work and express my displeasure with my husband who runs this company called Meslite. It doesn't actually make anything but t-shirts for Frito apparently, but somehow it belongs on my disclosure slide. You know, they always ask us to disclose things like this, but I actually think it's more important to disclose things like this, which is you will find that, my lens is a surgeon's lens. I'm a vascular surgeon, and, I often have more empathy for the surgical perspective than anything else in my research. And I think all of us are, sort of obliged to say, this is where I'm coming from, and this is how I see it. And I think it's important to disclose that. The second piece is that while I am trained as a bioethicist, and I think that a lot of the problems we have in communication are based on bioethicists not doing quite the right work to get it right, I want to be really clear that I don't mean like any bioethicist you know, I don't mean me. I think they really came up with some great ideas in the 50s and 60s and then failed to do the empirical work to figure out how these played out clinically. There's this really awesome Seinfeld episode where one of Jerry's friends becomes Jewish so he can tell Jewish jokes. And they say to Jerry, does that bother you as a Jew? And he says, no, that bothers me as a comedian. And so I realized that as a bioethicist, I have special privilege to call out my group. And then finally, I don't have all the answers. I have some ideas about things that we can do better, but they're not sort of one size fits all solutions, and it's not going to answer all of our problems. And maybe the last thing I'd like to disclose is that as a surgeon, I always feel a little off my game presenting to medicine clinicians. I'm a plumber, and you guys all know a hell of a lot more about medicine than I do. So the take-home points are really mostly about palliative care, which is that all of us who take care of patients with end-stage kidney disease take care of patients with life-limiting illness, serious illness, and for many of these patients, given their short-term and long-term survival, they would benefit from palliative care. But it is really hard for these patients to understand why they would benefit based on their lack of prognostic understanding and the fact that their illness trajectory is typified by a slow overall decline with interval catastrophic events without full recovery. It's not a disease that people think of as a terminal illness, much like people would think of something like, cancer or Alzheimer's disease. And then here's where I like to call out the bioethicists, that the standard probabilistic language that we've all been taught to use to talk to patients about procedures, to talk to them about interventions, even to talk to them about survival, is inadequate because it doesn't allow patients and families to anticipate and prepare for events that they might experience along the way. And then finally, older adults with end-stage kidney disease receive less high quality end-of-life care in comparison to so many other patients with life-limiting illness, whether it be COPD, heart failure, cancer, and even dementia. You guys might think, well, these are my people. Why is she talking about my people? But I just want to say that your people, they die on my service, right? They show up with ischemic events, like we amputate one leg, they go back to a nursing home and come back and we amputate another leg. It is a really sad thing to watch, knowing that their overall trajectory is actually really quite poor. And I do think we could do a better job of supporting them. So there's this lovely expression that if you don't show me data, I won't believe you. But if you don't tell me a story, I won't care. So I'm going to start by telling you a story. Full disclosure, it's a surgical story, but I hope it will illustrate my point about probabilistic language. So this story is about a patient who showed up at our hospital many years ago at this point. She was in her late 70s. I think all of us might describe her as frail. And she showed up in the emergency room with a tender thoracoabdominal aneurysm. She was on home oxygen. She had a wonderful family and was just barely making it at home because they gave her a lot of support. My colleague went down and talked to her and her family about whether to proceed with operative intervention. And he said, if we do surgery, you have a 50% chance of dying. He said, if we do surgery, you have a 60% chance of being on dialysis postoperatively because her baseline creatinine was running in the tubes. If we do surgery, you probably have an 80% chance of getting stuck on a ventilator longer than you would want. And, very appropriately, he offered them an alternative of comfort-focused palliative care. So she and her family thought long and hard about what to do, and ultimately they decided to move forward with surgery. So the next day he took her to the operating room. They did this big, huge procedure, cut her from, scapula to pubis, and did this huge incision, took them about 10 hours, lots of blood products. The following day, she was in the ICU and the surgical team rounded. And, she looked pretty good. She wasn't on a lot of pressure. She didn't require any blood products. She was holding her own. She was even making a little bit of urine. A few hours later, her family came by. And you know exactly what they saw. She was puffy. There were tubes sticking out of everything. There was a whole run of drips running behind her. And she didn't even squeeze their hand. And they took one look at her and turned around and looked at the team and said, no, this is not okay. She never would have wanted this. And they asked the ICU team to withdraw all of her life-supporting treatments. So if I had to describe what happened to this patient, I would say that she received unwanted care. And if I had to explain why this happened, I would blame it on the process of informed consent and the language we've been taught to use in order to help patients and families figure out whether surgery or any other procedure is right for them. And you can just imagine how she and her family put this together. If there was a 50% chance of survival, there's a 50% chance of not surviving. If there was a 60% chance of being stuck on dialysis, there was a 40% chance of not being stuck on dialysis, and an 80% chance of getting stuck on the ventilator and a 20% chance of not being on the ventilator. And they went down the list, 50, 40, 20. And they were like, she's got a 20% chance of being exactly like she was before surgery, after surgery. When I guarantee you there's not a person on this webinar who would think that that is true. And I do think we've been set up with this language about how to talk about things with patients that in a way that misinforms patients and families about the consequences of these decisions. So my lab has developed this intervention called best case, worst case, and it's a bunch of things. And in full honesty, we developed this for acute surgical decisions. And just to forecast what I'm going to talk about later, we actually have modified it for decisions about life with and life without dialysis. So the intervention is two things. The first is this graphic aid, which you can draw with a simple pen and paper diagram. Each vertical line represents a treatment option. For this patient, the treatment options were surgery or comfort-focused palliative care. But you can imagine a whole different ranges of things that you could put. Even you could say a major operation or a smaller operation. Right? It doesn't have to be surgery. It doesn't have to be comfort-focused palliative care. But for this patient, those were the options. The star at the top represents the best case scenario, and the box at the bottom represents the worst case scenario. And the oval in between represents what we might think or where we might put as clinicians on the line where the most likely scenario might fall. But more importantly than the graphic aid, although I do think it is important for patients and families to hold on to and have something to reference, is something called scenario planning. And scenario planning is a way to describe the consequences of what happens when we move forward in a certain way, or with a treatment or with an operation. And the idea is that we, instead of just talking about the outcome, we talk about not just the outcome, but the events experienced along the way. So it's not just survival, but all of the other things that need to occur in order to get to this place that we call survival, and then some description of what we mean when we say the word survival. So what might we have said to this patient and their family about what the best case scenario with surgery is? Well, in the best case scenario, we're going to go to the operating room. We're going to be there all day, and there's going to be a really big incision from her scapula down to her belly. The next day, she will need to be in the ICU and probably on a ventilator, and she'll probably need to be there for 4 or 5 days. If we're really lucky and she doesn't have any complications, we can get some of these tubes out of her and get her out of the ICU and get her up in the hospital for a while. But really, this is a long recovery, and she'll probably need another 10 or 15 days in the hospital in order to get just enough strength back to go to a nursing home. And then I have to tell you, I do think that it's going to be very hard for her to get home from a nursing home because she was just barely making it before surgery. And I really think that the surgery is going to set her back enough that she's probably going to need nursing care for the rest of her life. And that's in the best case scenario. The other thing scenario planning allows people to do is to isolate the uncertainty. We don't know how it's going to go, but we have a good imagination and a good visualization of what it looks like to go well. And we have a good visualization of what it looks like when things go poorly. And I have to tell you, when we did focus groups with older adults in Wisconsin, looking at, sort of trying to develop this, for me as a surgeon, the worst case scenario is I take someone to the operating room and they die on the table. But that actually didn't sound so bad to them. You express a desire to live, you go to sleep, and you never wake up. So the worst case scenario is actually worse than that, which is you go to the operating room and then you languish in the ICU as complication after complication after complication builds up. And 3 weeks later, your family makes a decision to withdraw life-sustaining treatments. So I want to say that it's shocking to me that we use the strategies now that we're using around probabilistic language and risk benefits and alternatives for informed consent when scenario planning has been around for years. It was actually developed in the 40s and 50s for military planning by the Rand Corporation and then popularized by this economist named Pierre Wack who worked for Shell Oil. And he said, the economists in industry are constantly talking to managers, and the managers need to make decisions, but the managers freaking hate the economists. They're like, you're always wrong. And the economists are like, well, we're not wrong. You just don't know what to do with the information that we're giving you. And he said the way that scenario planning works is it allows the decision maker, the manager, to understand the interrelated parts. It helps them isolate uncertainty and then prepare in order to hedge their bet and make sure that they've accounted for the way things can go. And I think that that's really different than saying, you have a 60% chance of having war in the Middle East break out, and should you build a refinery there? It's not that it's wrong if it doesn't happen, it's just not helpful. I'm going to show you a slide that it's possible I stole from a local university. And this is from March 2020, and you can see exactly what they're doing. They're using best case, worst case, or scenario planning to try and figure out how to manage the pandemic and what they have in store. And as you might imagine, there was a ton of uncertainty in March. I would suggest most of the stuff on this slide is wrong. Simultaneously, all of us are in places where we have this probabilistic data coming at us, and then we then need to interpret it for patients and families in order to make a decision together. All right, so here's the story of how best case, worst case surgery went, which we affectionately call the OG version in my lab. So, as a young investigator, I was like, great, we're going to do this nice RO3 funded study. We're going to do a little pilot study, and then I'm going to make it right in RO1 and it'll be awesome. So the good news about that plan was that surgeons can do it. And they actually like it, which is helpful. But we did show improvements in shared decision-making using this measurement called option 5, where you audio record the conversation and then you give, little numbers, you score their conversation. So you can see before the intervention, surgeons actually scored pretty high on the shared decision-making scale, about 40 or so. And then after the intervention, not only did they score higher, but the variation between surgeons decreased quite a bit. And you can see how this worked out. This is a patient, again, on the vascular service. This is a 90-year-old farmer who came in with forefoot sepsis, and the choices that he was offered were amputation versus home with hospice. And you can tell, this is a really tough decision. Ultimately, he and his family decided to move forward with amputation. And yet I think they still had this understanding of what things would look like afterwards in a way that allowed them to prepare for things when they didn't go well. And this is the kind of stuff that we audio recorded that makes me feel like, it's really supporting patients and families with shared decision-making, which is that when you describe a story about what things might look like, how the patient might actually experience the care, you can hear back from the family member, you can hear back from the patient what they think of that. What do they think about being on a ventilator for a week after surgery? What do they think about losing some of their independence because they now need more nursing care after whatever it is we're going to do? And so ultimately, the surgeon goes on to help this family and say, this is what I know about her. She didn't want a lot of these interventions. So my general thought is that we probably shouldn't do surgery because all it's going to do is end up providing this kind of treatment that she's already told us she doesn't want. Okay, so my young self was very unhappy with the results of this study, not because we didn't make improvements, but because it actually is a really hard space to develop a large-scale clinical trial. So first of all, it was just really hard to run around the hospital and enroll patients to be in this study. I had a surgical resident running around like a golden retriever, enrolling patients moments before the surgical attending walked in the room to have this conversation. It's just not a feasible study design. I would say the biggest problem was this idea of cohort heterogeneity, meaning that the patients we enrolled had things from aneurysms to obstructing colonic masses to, new pleural lesions. It's really hard to study outcomes when everybody in your sample looks a lot different. And then I would say that in this world of decision science, people are really enamored with this idea of decisional conflict. And they sort of think that if you have a good decision, then you'll be less conflicted about your decision, that somehow this is a marker of good decision making. And the problem with that is that I can say, look, if you don't have surgery, you're going to die and you will move forward with surgery. But I will have no idea whether that surgery is consistent with your goals and preferences, and you won't be particularly well informed because I will not have told you all of the details about that. And so your decisional conflict will actually be very low, even though the things we care about around decision making, like goal concording care or patients having the kind of information they need in order to be feel like the decision they made is worth it for them, those things haven't actually been addressed at all. I do think actually to make a good decision, we need to get people into a deliberative space. And so decisional conflict may actually need to rise in order to have a good decision and then fall over time. So then the question is, when do you measure it? I think the last thing to think about, and I'll talk a little bit about it as I talk about this new study with our older adults with end-stage kidney disease, is this idea of what is a good choice, right? For some people, a good choice is to have surgery. And for other people, a good choice is to have comfort-focused palliative care or best medical management or some other thing. And I can't actually know that when I start the study. Right? And so if you're really being honest about shared decision-making and you really care about patients receiving treatment that's consistent with their priorities, then you can't go into the study and say, well, I just want people to have less surgery, or I just want people to have more surgery, or I want fewer people on dialysis. That's just not, it's not supportive of the notions of shared decision-making. And it's not really coming out with the outcomes that we care about, which is that the treatments are consistent with what patients actually prioritize. So, so I tried to design the study for my OG version in acute care surgery, and I just couldn't. So I looked around my world and tried to find a more homogeneous population. And, as I mentioned earlier, these are your people, but they're also my people, right? Which is that our patients end up with worse end-of-life care outcomes than just about any other group. And it's a lot because of the nature of their illness. It's a lot because of the difficulty projecting prognosis. And it's also just about how it plays out. And, if I think about sort of the hard patients that I take care of, the sad stories, it's really this sort of in and out of the hospital at the end of life without any sort of support around trying to get them some palliative care to manage their symptoms or do good end of life care planning, good advanced care planning. And so it really seemed like there was a lot of need, both for the patients that I was taking care of, but also in this upstream space where these patients, older adults who were not seeing a real, who we couldn't confirm that they'd have a survival advantage with dialysis, that they, this decision about whether to start dialysis or not it's a big deal. And they were kind of similar, right? All of these patients, you could project their mortality based on age, based on comorbidities, based on a few other things that we've included in our study. And so then the question is, how do we talk to them in a way, and would best case, worst case be helpful for them? So I got a very nice grant from the National Palliative Care Research Center to adapt best case, worst case OG for nephrology. And I'm just going to show you a little bit of data from our study here. So, so really it's a question about life with dialysis and life without dialysis. And the goals of this study were to really adapt it. It is a very different decision than an acute care surgical decision. And then to demonstrate that nephrologists could actually use the tool. I assume that people trained in internal medicine would be awesome at this, and I didn't even need to do that. I, kind of always think that the surgeons maybe need more help than the nephrologists, but this is a really different way of talking and communicating with our patients. And so I'm pretty happy that this was part of our pilot study, the sort of thinking through what kind of training people would need in order to do this in their clinic. I would also say that nephrologist has a disadvantage that I didn't realize. So as a surgeon, every time I go to see a patient, I'm always thinking surgery, not surgery. Does this patient need surgery? Do I need surgery? I need to talk to them about surgery, right? So I'm always in this space of, are we going to operate? And I can't operate without getting informed consent, right? That is an absolute requirement. But it's different in nephrology clinic. And, we have a lot of audio recordings of from our pilot study, and this space that exists in surgical clinic when I'm going to talk to somebody about surgery is a much smaller, if not sort of more latent hiding space in nephrology clinic, right? You have all these other things that you need to talk about, potassium and don't eat peaches and all of these things that I don't even know what you're talking about. But, you have this other thing that needs to be accomplished, and that space for decision-making isn't quite as big. So a lot of this pilot study was used to figure out how are we going to generate that space in nephrology clinic. Then we wanted to see how patients and families responded to the best case, worst case tool in clinic. And then the rest of the things were really about research and how would we study this. So just thinking about the differences between surgery and nephrology, so the outpatient setting versus the inpatient setting is obviously very different, right? Outpatient clinical medicine happens over time, where surgery happens sort of in one moment of time, and that is actually something hard to manage. The urgent nature of surgery versus the chronic progressive illness is different. And so when you're thinking about something like scenario planning, you need to tell both an acute story and a chronic story. And so how we were going to fit that into these stories was really important. The treatment types are obviously different. And then again, the trajectory of illness was very different. So here's how we did our pilot study. We had 12 patients in our pre-intervention group. And again, the pre-intervention group was this space, at least for me, to really understand what are the barriers in nephrology clinic to using this and really trying to understand what that appointment was about. We then trained all of our nephrologists who had a practice that was amenable to this here at the University of Wisconsin to use best case, worst case. And then we did our post-intervention study. And I'm just going to put this out for those of you who are interested in research. If you do the pilot study at your center, you have then burned your center for a future study. So, none of our study sites in our current R01 funded study are here. And that's because we already trained everybody here to do this. And then we had 18 patients in our intervention group. So what did we find? So the best thing is that nephrologists are just as good as the surgeons at using best case, worst case. We have a checklist of intervention criteria to make sure that it's going well. And you can see that, this is a graphic aid that was used in somebody's clinic to talk to a patient about life with and life without dialysis. So, you're dead in the water if the clinicians can't do it. And, I'm just thrilled that the nephrologists were A, willing, and B, able to do it. And they definitely can do it. In a pilot study, it's always hard to look at these tables because it's just really small numbers. And I think, if your pilot study is powered to see a difference, then why are you doing a pilot study? So really, I was very happy to see that we got some more patients into palliative care. That was really sort of what we were looking for, but I don't know that you can make heads or tails out of these numbers. They're just too small. And then finally, we saw this similar trajectory with our shared decision-making scores as we did with surgeons, which is that scores on shared decision-making started off a little bit lower and then improved over time with the best case, worst case intervention. We did, just like for our best case, worst case surgery version, we went to patients and families' houses afterwards and interviewed them about their experience in clinic with best case, worst case. And they were, for the most part, very enthusiastic about it. They liked this idea that you could see that there were two ways to move forward with their treatment. And they really like having the piece of paper, like it's a helpful reference to them over time. I think it also really helped them develop the kind of language that they wanted to use in order to talk with their clinician about the consequences of starting dialysis. And then I really like this idea about preparing, right? Regardless of what we decide to do, when people can have some sort of anticipation about how it's going to go for them, when they can see it in their mind and imagine what it would be like to go to dialysis 3 times a week. What would it be like to do that week upon week? What would it be like to have these moments where we need to move in and out of the hospital because of the complications that come up along the way? It allows them to at least prepare for that. And that doesn't mean it's not aligned with their preferences. It might be very well aligned with their goals and values and their ultimate priorities. But I think that, when we talk to our stakeholders, the thing they hate the most, they hate being blindsided. They hate this idea that all of a sudden they were thrown for a loop. And when they had this sort of understanding of what things might come next, they were at least able to sort of mentally and I think even sort of emotionally and physically prepare for what things might be like over time. So what did we learn from this study? So the first is we have this nice deliverable and you can go get this online anytime you want. Although if you're going to be in our study and you're in the control group, please don't do that. But anyway, so we have this pre-printed graphic aid that can be used in clinic anytime and anyone can use it. I have to say that the graphic aid alone is probably not enough to do it. It really does require some training to change how we talk. The other thing is an instructional video. So we now have 3 whiteboard videos in my lab. The first is the OG surgery version. The second is the one for nephrologists, and we have a new intervention for the intensive care unit. They're all available on YouTube. And then the third is, successful funding for an R01. So, this was funded in June of 2020, and we have 8 sites currently participating all over the country. Wonderful nephrologists. I've so enjoyed this group of nephrologists. They're just delightful, wonderful people. Our goal is to enroll 320 patients who are age 60 and older with an expected mortality of 18 months or less. We have some criteria to do that, the Rollins criteria, the age criteria, and also we use something called the surprise question, which is, would you be surprised if this patient died in the next 12 months, which is actually fairly sensitive for mortality. So the intervention is mitigated at the clinician level, meaning that rather than most randomized clinical trials will randomize at the patient level. The problem with that is that once you've trained a nephrologist to do that, they may end up using it, not intentionally, but use pieces of this with people in the control group. And so to mitigate this contamination problem, what we've done is trained the nephrologists who are randomized to the intervention group at the start of the study, and then nephrologists who are randomized to the control or usual care group have the opportunity to get training in the intervention at the end of the study if they're so interested. Our outcomes are kind of all over the place, lots of different things in decision science that you might want to measure to see if your intervention is better. I do really like considering things like quality of communication and quality of life, particularly for patients with life-limiting illness. This is really different than so many of the studies we're used to reading that look at survival as an outcome. And then the question about how do you use death in your study to figure out whether things are good or bad is an interesting intellectual and statistical issue. But really critical for our patients with life-limiting illness to get this right. I want to be clear that while we are measuring and comparing the decision to start dialysis or avoid dialysis, that is not a primary outcome. And again, this goes back to this notion of being honest about what you care about when you are trying to improve shared decision-making in clinic. I just worry that it would be really corrupt to say we need to do less dialysis, and the whole reason we're doing this study is to see if we can do less dialysis. That's A, not fair to the patients, but B, it's a value judgment that I'm not sure any of us are really willing to make. This doesn't mean that for some patients it's not better to avoid dialysis. It just means that I can't figure that out ahead of time. So here's where we are now. Starting a study in June 2020 is really not great. And I don't think I need to tell anybody that working in the pandemic sucks. It does. We have enrolled 75 patients in this study. And so we're a little bit behind, not dramatically behind. I think the fact that we're still swimming and we're still moving forward is pretty incredible. And I really want to give a huge shout out to my colleagues who have been able to continue to pull this off at their study sites. But we're in a position where we really need to add 2 additional study sites. And so Northwestern has been at the top of our list because we actually talked about this before the grant even went in. And so I'm super grateful for all of you just being interested and willing. And then the other site we're going to add is the University of Colorado. So I'd be happy to take questions. I'm a surgeon and a bioethicist. You'd think I'd have really thick skin. I don't. So I'm happy to answer questions. I guess you can't really throw rocks at your computer and hurt me. So maybe you could throw rocks at me, but hopefully I can answer your questions. Thanks so much.
Thank you so much, Dr. Schwarze. This was a wonderful presentation. Thank you. I will, read any questions placed in the chat box or in the Q&A. One question that I have is, this is really, a much needed tool in our field. Now, thinking, ahead in terms of applications, how do you think, for example, health literacy, cognitive dysfunction, could affect the performance of the tool? And could you proactively make revisions, amendments down the road so that, this basically, patient population is also more effectively captured?
Yeah, I love that question. And I think, the cognitive piece is a really critical one. So we're actually enrolling caregivers and patients in our study. And I think one of the things that the graphic aid does is help get everybody on the same page. So, and we found this in our surgery studies as well, is that the patient family or the caregivers or whatever you want to call them really found the graphic aid as a very, very helpful reference. In our pilot study, we had a patient who had the best case, worst case intervention in clinic, and then got admitted acutely, a month or two later for some illness. And she brought the graphic aid with her. And I do think like this idea of providing a narrative about what things might look like moving forward. It doesn't mean I know what's going to happen moving forward, but I have some plausible story about what it might look like, and we can revise that over time. As far as the health literacy goes, we ask a lot of patients as far as numeracy, and I'm not even sure that the numerical information is as helpful as allowing people to sort of use storytelling to think about what it would be like to experience care. And so, one of the investigators I really like is Angelo Volandes. He does a lot of work in decision making as well, and he shows people videos. And again, it's the same idea as like we're trying to use imagery about what the experience of care is. And I think that for patients who have low health literacy, that is a much more robust strategy to try and help them than to say, well, you have an 80% chance of this or a 10% chance of that. Or even, your mortality at, 6 months is X.
That sounds great. So I have a question from Dr. Lee Lindquist, who is pointing, great talk. Have you thought about measuring time out of hospital or time at home for a metric outcome among seniors? So many seniors value remaining home, aging in place.
Yeah, Lee, I love that question. And I love that measure too, right? Like it really, it's not hard to imagine that people value time at home more than they value time in the hospital. So it's something you could count, and it's something that has sort of intrinsic face validity as being an outcome people care about. Study design is like, I could sort of geek out on study design all day. And simultaneously, it ends up getting really frustrating really fast with these pragmatic trials. And it's really about the heterogeneity of the group. And so, if people don't live that long, then how do you account for the people who lived only 6 months versus the people who lived 2 years? How do you compare their time in versus time out? You end up with some immortal time bias problems. They're just, there's a whole ton of sort of study complexity that makes it really challenging to measure, but I would love to do a study someday that uses that outcome. I'd love it.
Great. We have a question from Dr. Friedwald, who is, saying that thank you for the great talk. Well, he was paged a couple of times, but he mentions that these conversations would be very relevant also in the setting of transplant candidates. And he's asking if you have any thoughts about expanding these scenarios in patients who are considering to accept an organ offer, for example.
Yeah. So Frito and my husband went to college together, and my husband's a transplant surgeon. And so I try actually really hard to stay out of the transplant space, mostly for political reasons. I don't want him to show up at some meeting and be like, your wife is that crazy lady. So some of it is just sort of personal preference to stay out of the space. I think it would work great for many transplant patients. And just to, my husband's sort of feeling about best case, worst case is best case you live, worst case you die. Obviously, there's a lot more to say than that. And I think that some of the times when people talk about transplant, it's sort of this life-death decision, and patients don't get enough of an understanding of what it would mean to support a transplant, the challenges that entails. And that doesn't mean they would make a different decision, but I do think we could prepare them a little bit better for doing that. I have several K-Award mentees who are adapting best case, worst case to their space. And Frito, just to let you know that Pete Reese and I are mentees on a K at University of Washington, where the mentee is using best case, worst case, actually thinking about transplant workup, given how much of a burden that can be for some older adults. So I think there's a lot of opportunity to use it. And I think if you have anybody who wants to use it in their own space, I'm all in. But I can't be the leader of that. I will support it.
We have another question from Dr. Isakova, who is asking, in addition to applying to decisions about organ offers, are there applications to going through transplant clearance process in the first place, for example, among an elderly, about using nephroprotective medications that have side effects and may add to polypharmacy, especially among elderly?
Yeah, I mean, Tamara, that question is just completely brilliant, right? So that's exactly what my mentee Kate Butler is working on. I mean, I think that you know, you've hit the nail on the head about the burdensomeness of that process, and she and Ann O'Hare and Pete Reese and I are sort of trying to be in that space. But if you want to join us, we're all in. Yeah, it is a great question.
Definitely exciting applications. And if we think, you know, more generically, I mean, you are developing really a great tool that has fantastic applications in the medical field. I mean, is there like a way that, you know, someone can actually predict settings where, you know, the tool, you know, will perform well in an unbiased manner, quantifying, you know, how uncertainty plays into the prognosis of, you know, these patients? Or, you know, it will be more like someone is interested, you know, in this specific condition, they want to jump and apply your tool?
Yeah, so I love that question because you've captured like 20 different things in decision science that really need to be addressed. And I think that, you know, best case, worst case isn't for every decision. But there are lots of decisions it would probably be supportive of. And then, you know, sometimes the devil is really in the implementation as opposed to in the conceptualization. And all of these things matter in order to change care. And so, you know, I love research, and I think that all of these are really great empirical questions. And they're the kind of empirical questions that if you don't actually sort of attend to, then things don't get done particularly well. And I do think that you know, I hate to harp on the bioethicists over and over again, and yet I feel like this idea of how do we support patients and families that they had in the 50s and 60s, it was awesome, right? This whole idea of supporting people's autonomy and doing better to make people informed, and yet they didn't watch how it played out clinically, right? They had these great ideas, but, you know, my lab, like we go into the surgeon's office and we turn on the tape recorder, right? Like a digital tape recorder, but you know, like I have 600 conversations in my lab library trying to figure out what we can do better. And so all of those things that you just said are, you know, are totally germane to this type of research. You know, where is it vulnerable? How does it get done well? What settings work for this? What settings don't work for this? What's the mechanism of action? How does this play out?
And I guess, you know, as a final probably step, what will take in terms of implementation to convince, you know, institutions, you know, insurance companies to support actually, you know, this path, which takes time, has great outcomes. So what do you think, you know, besides convincing clinical research data, you know, will take to see this happening as part of clinical practice?
Yeah, that's a great question too. I mean, incentives matter. And there's no doubt that we do things that we're incentivized to do one way or the other, whether it's direct financial incentives or how much time you have in your life to do things. I have to tell you that, you know, when I give talks like this to surgeons at the end, they say, I love what you said. I'd like to do it more, but I don't have time. And, you know, I say back to them in this like super snarky way, I said, you know, I've been to a lot of surgical meetings and people will stand up and talk about, you know, doing extended lymphadenectomy for this or stents all over the place for that. And I never see a surgeon stand up at the end of that talk and say, I don't have time for this. And so while I get the time issue, right? All of us feel like we don't have enough time. It's real. And, you know, when I'm on service, I just feel like just book the case, just keep going, right? We're just trying to get all the work done. But I worry that when we say that that's a problem of time, we're missing the point, because I worry that it's maybe not about time, but what we care about or how we get paid. And so I think the kinds of things that we need to think about in order to do better for our patients are not just about time, right? It's about developing a system that cares about making sure people get what is appropriate for them and not just appropriate for everybody, or, you know, really supports how you actually have to go through the care, as opposed to we need to do this or you'll die.
I totally could not agree with you more.
Just a word on implementation of this. I have been thrilled that the nephrologists in our study have been able to incorporate this in their clinic without too much difficulty. It definitely needs support, and we definitely have ways to support people. The training takes about 2 hours, and we will reimburse you for your time for that. And then we've had multiple sort of a few 20-minute sessions with support from our educators. But this is a very learnable thing. And, you know, I've just been thrilled that the response from the nephrologists in our study has been extraordinary. Like they're really engaged. And, you know, my surgeons tell me they use it all the time. I'm not sure what they're doing, but I can tell you that I know that the nephrologists are doing this. And I couldn't be more thankful about a good collaboration.
That's great and very, very encouraging, you know, for our community. Well, I don't see, you know, any other question posted. So with that, I would like to thank our speaker for an exciting talk, our participants for joining, and for more updates from, you know, our division, please stay tuned on Instagram and Twitter. And have a great day, everyone.
Thank you so much. I really appreciate it.